Good afternoon. I realize it's post-lunch, so hopefully I can keep you engaged here. So I thought I'd start with a case here. This is a patient that we took care of at our children's hospital. It's a 9-year-old kid who came after a pellet shotgun and developed a right visual field. And you can see with the arrows why he may have a visual field cut there. We did do an angiogram on him, mainly to understand his collaterals, to see how best to manage this. And what you can see on this panel B is that on the sort of axial, or sort of, I guess this is more like a coronal view, you can see there's a occlusion there of the left PCA. And if this video works, you can see as we went up to do the angiogram, just on fluoroscopy, this kid had sort of a splatter of pellets, and you can kind of see how this ended up going up intracranial. So he had no cardiac injury, no PFO, no actual skull penetration. This was just penetrating injury to the body, and then one of these pellets became intravascular, likely from the heart, went up to the PCA. And in this case, we thought about potentially retrieving the pellet. We thought the best opportunity to remove it would be acutely, but he actually clinically was doing pretty well, and he had just a visual field deficit, and at that time we weren't confident that our aspiration catheters would be adequate to retrieve the clot, and we were not sure how much injury would be applied to the vessel. So these are sort of illustrate some of the challenges we face in pediatrics. Some of the mechanisms of stroke are not their typical atherosclerotic mechanisms. Dr. Fox already talked a little bit about the epidemiology. So the problem in kids is that strokes are rare. When they present, often they're not necessarily strokes. There's many mimics, which makes us think less likely that it's a stroke. And then the evidence is really lacking in terms of how to best manage these patients in terms of IV TPA or thrombectomy. And that's, I think, somewhat colored our way of thinking about how to approach this population. But the 2015 guidelines did change how we think about this. So at present, there's more knowledge gaps, as the previous speaker alluded to, and we really need to understand this population much better. So this is another patient we took care of. This is a child with hypoplastic left heart syndrome. He's waiting a transplant, developed left-sided weakness and right gaze deviation. And you can see in many of these cases, we end up getting advanced imaging because there are mimics. So in an adult, perhaps we would just do a head CT, CTA perhaps, and go to thrombectomy. In this situation, in a child, even though the pretest probability with the heart disease was that it was going to be ischemia, we did get an MRI with perfusion. You can see there is a small core relative to the tissue at risk. In this case, we did pursue thrombectomy. Presumably the mechanism was cardio-embolic. And in this age population, we actually end up using the same sort of catheters that we would in the adult population. So this is sort of a straightforward manual aspiration thrombectomy. And this child improved and was able to get well enough to undergo a heart transplant. And this was 8 hours out. So this was really right after the late time window trials, but in this case, the child had a mismatch. And probably time is really irrelevant as we think about this population as we would with adults. So what's the challenges here to doing a randomized trial? So, we know that the major trials excluded children, so there's very few cases. There are some concerns about whether the same devices would be adequate in children, and I think the specific population everyone gets nervous about is arteriopathies or focal arteriopathies, where if you think the problem in the vessel is somehow intrinsic to the vessel itself, like a Moya-Moya type process or a post-infectious or inflammatory arteriopathy, I think there's a lot of anxiety about whether our catheters are safe in that population. And then there's always the issue of if something works in adults, is it ethical to then do a randomized trial in children? And I think that's going to create issues in terms of lack of equipoise. So it seems like if you look in the literature, there's every 6 months or 12 months another meta-analysis of pediatric stroke. So this is the most recent one that I could find. And, this one looks across 20 years. 110 patients was the largest one in the literature. This is from the Toronto group in collaboration with Mount Sinai. And what you can see right off the bat is that there's very good recanalization rates, excellent rates of good outcomes, and a pretty good safety profile. So this is sort of the bottom line. But of course, these are meta-analyses of single center series, a lot of bias in terms of what's published in the literature, but it gives us some sense of what we're looking at. So Dr. Fox alluded to age. So certainly less than age 5, we worry about the ability to use the same catheters. The vessels are not adult-sized vessels yet. And there's also access site issues. But you can see most of the kids that are involved, in this series at least, were above age 5. And there's a slight bias in terms of more males than females. In this series, again, I think there's a little bit of bias in terms of what gets put in, or what people attempt to do a thrombectomy. So majority were, or I should say the plurality were cardio-embolic in mechanism, and then there's hypercoagulable states, et cetera, dissections as you'd expect. And again, I think that probably arteriopathies get underrepresented because those are the ones we tend to pass on when we are involved as an interventionalist. The site of occlusion is what you would expect. M1 and ICA terminus are the majority, and then the posterior circulation about 20-25%, as we would see in the adult population, maybe a little bit higher. In this series, they used a whole a whole set of devices, predominantly stentrevers. Again, I'm not showing you here, but if you look at the number of cases that are published in the literature, they did sort of spike up after 2015. So many of these cases were done in the stentriver era. But you can see people using aspiration. There's older cases with Mercy device. So really, the same devices we would normally use in the adult population have been used in children. And again, IVTPA was given in a subset of the population. Let's see. So, as far as we can tell, currently, the most common mechanism in kids is cardio-embolic, or it's one of the major mechanisms. It probably is the mechanism that we tend to treat endovascularly, although I think the focal arteriopathy population is one that we need to understand better, and there is some interest in using vessel wall imaging to identify and risk stratify that population. In this series, there were more males than females, a little bit older population in that there were more kids above age 5. The distribution of occlusions is comparable to what we've normally seen. And then just a few sort of caveats here in terms of the pediatric population. The general recommendation for any kind of angiography with a femoral approach, at least, is if you're less than 10 kilos to use a 3 to 4 French catheter, 10 to 20 kilos, 4 French, and then above 20 kilos, 5 French catheters are used. And certainly when we do thrombectomies in the teenage population, we tend to use very similar devices, 6 French shuttle or Neuron Max if it's a larger child. There is some dose limitation to be aware of if you use intraarterial TPA. So in this situation, again, we have a very limited understanding of the population less than 5 years of age, even less understanding about neonates, infants, and what is the best devices to use. And you have to get a little bit creative about what can be the largest catheter that you can use safely. There are higher rates of arterial occlusions, arterial site occlusions, especially in the underweight or young population. And you have to keep in mind that when these patients are presenting with symptoms, they may have had previous access issues related to their underlying condition, such as kids who may have had ECMO and that sort of stuff in the past. So this may limit access sites. The Stroke Trial Network has at least one proposal looking at the pediatric population. So this is a study that's being proposed through the Stroke Trial Network from the Stanford group. So this is a study called PETITE, which is a multi-center phase 2 study. And what they're really proposing is in this population, we maintain a registry of kids who undergo treatment and to treat children that have the target mismatch, as is defined in this table here, very similar to the target mismatch that was defined in Diffuse 3 or in the other sort of Extend trial. If you look at the practice patterns, people are becoming more and more receptive to endovascular therapy. So I'm just going to end here, but I think probably the next step for endovascular therapy is not going to be a randomized trial, but likely some kind of registry. And what I would really advocate for as a community is that we do maintain a prospective, multi-center, multinational registry of both treated and untreated large vessel occlusions, and then think a little bit about the pediatric specific clinical endpoints that may be more relevant in that population than in the adult population. So I'll stop here. Thank you.